Welcome everybody. We're going to start on this lever chapter, physical agents. Basically, we'll be talking about things like heat, cold, radiation, and trauma. So we can go ahead and get right into this with the PowerPoint presentation where I'm going to outline things. And then afterwards, I'll be doing a few unknowns, just random things that have been selected from this chapter. So we'll start off with heat-associated injuries. These can basically be divided into several categories. We have thermal, we have chemical, and then we have electric. There's different ways of dividing these things, or at least measuring them, based on partial or full thickness damage, or as we probably are more familiar with, first, second, or third degree. And exposure to direct heat is really the most common one. We see that quite often in derm path, and I'll show examples in a little bit. So we'll talk about burns. In burns, usually histopathologically anyways, you'll see neutrophils within the first couple of days. And then as the lesion progresses, maybe some macrophages and lymphocytes later, although this is not 100%. In second degree burns, there's separation of the epidermis from the dermis. That's kind of the defining feature. You get vesicles or bulla in second degree burn. By the time you get to third degree burn, you have involvement of the dermis and pilosebaceous units. And again, I'll show examples of this to kind of illustrate it a little better. Histologically, radiation differs from burns in that you often have these atypical fibroblasts. And I'll mention these a few times and show examples. It's a really helpful kind of a clue to define histologically radiation dermatitis. We'll talk about that a little bit more. So then I have to mention a little bit about burn-associated malignancy, just because it's it's different from other types of malignancies like squamous cells that we see that are UV induced. In burns, these malignancies can be much more aggressive and they can be very latent, sometimes up to decades later. Squamous cell carcinoma, as I said, is the most common, but you can have others. And again, these are very aggressive lesions compared to the typical squamous cells or other lesions that we see that are related to sun-induced malignancy. So here's an image from Whedon that shows an example of a burn. And we see some necrosis, some elongation, this kind of sort of squiggly epidermal nuclei that we see in these burns. So this is involving the epidermis, but additionally, it's also involving the dermis. You have this sort of basophilic or homogenization of the collagen. This image is from Lever's histopathology of the skin, and it's really illustrating more of a severe burn in which you have involvement of the dermis here. And this is what you want to look for in third degree burns, where you have obliteration, destruction of pilosebaceous units. So it's a very important defining feature for third degree burns. In this chronic burn scar, also from Lever, we can see that there's been effacement of the reedy ridges here and kind of obliteration of all adnexal structure. But interestingly, what I said before, often the differential will be, at least from a histology standpoint, will be a radiation. And what you don't see in burns are those radiation fibroblasts, these kind of atypical looking plumper cells, which we'll talk a little bit more about soon. So we can move on now to this acute ultraviolet injury, which is in its acute form, as we're talking about here, defined by sunburn cells, which I'll talk about in a little bit, or show you examples in a little bit as well. And these are just apoptotic or dyskeratotic keratinocytes. We often see them incidentally. We'll see a biopsy that's been taken for like a nevus or something, and we can often tell that the patient's been sun exposed or has acute UV injury based on these sunburn cells or these apoptotic or dyskeratotic cells. In extreme cases, you can get blistering from full thickness necrosis. This is just an exaggerated form of what we have here with these sunburn cells. You get the entire thickness of the epidermis involved. And then there's this interesting thing called ultraviolet recall, which is a condition where you get an eruption in an area that's been previously sun damaged because of the introduction of some medication, a chemotherapeutic agent, often methotrexate. And this is related a little bit to something I'll talk about later called radiation recall. So it's something to be aware of. So here's an example of sunburn cells, acute ultraviolet injury. You can see these Necrotic cells are kind of throughout the entire thickness of the epidermis, and that's distinguishes it from the sort of classic interface dermatitis where we usually see just the necrotic keratinocytes localized to the basal layer. And then this is a more extreme example where we get full thickness necrosis of the epidermis. This is an example actually taken from PUVA therapy. So it's a marked phototoxic reaction, but the same sort of process where you get, instead of just a few individual sunburn cells, you get necrosis of the entire epidermis, sometimes with the formation of bulla, because you get weakening at the dermal-epidermal junction and separation. So we'll change a little bit here and talk about Erythema ab igne, which is a condition you're probably familiar with. Repetitive exposure to heat causes it. And clinically, we often see this present as reticulated red to brown patches. You can have secondary bulla, and you can have something called thermal keratoses, which is, I think of it as kind of this atypia, jumbling, mild atypia of the basal layer, and sometimes full thickness. It can mimic an 8K, an actinic keratosis, or in some instances, a squamous in situ. But usually all we see is very, very subtle findings. You may see an atrophic epidermis, a little interface, a few dyskeratotic keratinocytes. But often the few cases I've seen of this, you look at it and you think it looks very normal. It's kind of hard to tell what's really wrong with it until you look closely and until you get more of the clinical history. So it's important to be aware of, correlate the whole thing, clinical pathologic correlation. Sometimes you can get pigmentary incontinence, variable inflammatory infiltrates. Unusually, you can get atypical endothelial cells. As I said before, this thermal keratosis type pattern can show atypia, sometimes mimicking a squamous cell carcinoma in situ. And fragmentation of elastic fibers is another finding, but also very difficult to see. So here's an example from Whedon. And again, as you can see, it's a very subtle thing. It's kind of hard to see what's going on, but there is a little bit of this sort of atypia that's confined to the basal layer. You may see an occasional necrotic keratinocyte here and here. So those are very subtle findings. So we'll talk about radiation-induced skin alteration now. Acute radiation is usually within 90 days, mostly erythema, but you can have other symptoms that include desquamation, erosion, and blistering. It's primarily an epidermal process. That's contrast to the chronic, which you get months later, and you get fibrosis of the dermis, and sometimes even pigmentary change. So these are kind of separated based on whether they involve the epidermis or the dermis. Histopathologically, in the acute variant, you can see dyskeratotic cells, and often you can have enough injury where you get sloughing of the epidermis. Dermal changes are milder, but you can have some endothelial swelling, some fibrin thrombi. And as I was saying earlier, in the chronic variant, you get this more eosinophilic homogenization of collagen. And as I've said a couple of times already, this radiation fibroblast, which is very helpful in the differential diagnosis. Also a little bit of vascular ectasia. And then the subacute, as we would expect, can show intermediary features. The interface process that you can see in the acute variant often looks a lot like a fixed drug eruption or GVHD. So you should include that in your differential diagnosis. So malignancies, again, there seems to be a common theme here. With the radiation-induced malignancies, you can get very aggressive squamous cell carcinomas, but not just that. You can also get sarcomas, and those sarcomas almost always will show aggressive behavior in any case, whether or not they're related to radiation. So if you have a difficulty telling the difference between some of the mimics in the chronic variant of radiation dermatitis, like morphia or lichen sclerosis, look for those radiation fibroblasts. And of course, the history is going to be critical there as well. And in deep burns, as I showed earlier, you can see an absence of eccrine glands that can help distinguish. So here's an example from Whedon of early radiation change. And again, it can resemble a lot of an interface process. You have dyskeratotic cells, mostly confined to the basal layer, but you can have them throughout the epidermis. You can think of things like fixed drug eruption or GVHD, so important to correlate with the clinical. Here's another example of radiation, but this one more chronic, also from Whedon. And you can see that the epidermis is really less involved here. And actually what you have much more going on is this sort of homogenization or fibrosis of the collagen here, and these ectatic vessels. Some areas you can see a little bit of these radiation fibroblasts, these kind of darker cells right here in center field. But this image from a lever actually shows it much better, I think. These are the radiation fibroblasts up here. Again, in this background of sclerosis, almost like a lichen sclerosis type collagen change. Vascular ectasia, again, illustrated very nicely here. And this image right here, if we didn't know anything else, you would really think about common things like lichen sclerosis, but this is, these are all actually examples of radiation. And I mentioned earlier that we had UV radiation recall dermatitis. So radiation recall dermatitis, kind of its cousin, and you get this acute reaction in a field that's been previously irradiated, induced by medication. As I said earlier, chemotherapy agents are often implicated. Methotrexate, very common, so important to be aware of that. So we'll shift gears a little bit and talk about cold-induced injuries. The three things we'll talk about here: frostbite, Pernio, and cryotherapy. I won't say too much about frostbite other than it's classified based on depth, and histologically it's almost never biopsied, so couldn't even find an image of it actually. But basically what you see is necrotic tissue. It's not going to be a very specific finding. So Pernio, on the other hand, will definitely be something that you see in the clinics and that we see under the microscope. So as we know, Pernio is often occurs in cold and damp conditions, patients who are exposed to these conditions. You get these erythematous or violaceous papules or nodules, which affect the extremities, which are the closest exposure to the cold. There's this particular case of equestrian perniosis that occurs in the thighs and buttocks of people that ride horses. So that's kind of a different sort of unusual presentation to be aware of. So you have these acute and chronic forms. The chronic form may be associated with underlying connective tissue disease. There's a lot of talk about telling the difference between lupus erythematosus related Pernio and regular or idiopathic Pernio. I'll talk a little bit more about that in a second. But there is an association with connective tissue disease, and Raynaud's phenomenon often occurs in older patients as compared to the idiopathic form. But the most important thing is correlate with your additional clinical findings, your serology, to really nail the diagnosis of lupus, if that is an association. Histopathologically, what we see is papillary dermal edema, often but not always. But the most characteristic thing is really the superficial and deep lymphocytic inflammation, which accentuates around these eccrine glands. And that's really the thing you want to look for. When you see an acrobiopsy and you see inflammation, lymphocytic inflammation extending deep down eccrine structures, then you really have to suspect Pernio. It's a very characteristic finding. Lymphocytic vasculitis, often you'll see endothelial swelling of the vessel walls, of the endothelial cells in vessel walls. It's sort of a harder thing to see, but it is something to be aware of. And the interface change is variable. There's some schools of thought that say that maybe you can use interface to tell the difference between idiopathic Pernio and lupus Pernio, although I think that that's probably a very difficult thing to do. Ultimately, you're going to have to rely on the clinical findings and the serologic findings as well. And of course, now it's very important to be aware that COVID is associated with Pernio. So we have to kind of alter our way of thinking when we see Pernio, not just idiopathic, not just lupus, but we have to throw COVID as an association as well. So important to get that history to see if there's any symptoms in the patient, and if so, make sure they get tested for COVID. So here's kind of this classic histopathologic presentation. The papillary dermal edema, the superficial and deep, perivascular and perieccrine lymphocytic infiltrate. Again, a very characteristic finding. At low power, you can really just make your diagnosis. You know it's acral skin. You got the hyperkeratosis, the lamina lucidum maybe, and then this, the rest of the picture here looks very much diagnostic at low power. Here's a little bit of high power showing the papillary dermal edema. So let's shift gears a little bit. Now we'll talk about cryotherapy-induced injury. And what you see is these intracellular ice crystals that you get from treatment from liquid nitrogen. And this very characteristic ghost-like changes or homogenization of keratinocytes, occasionally vesicle formation if you have full thickness necrosis. And this is from Lever showing very nicely this sort of pallor to the epidermal cells. In this case, it's even separated from the underlying dermis. So something we'll see very often, treatment with liquid nitrogen, often as a secondary artifact, though you'll see it at the edge of a biopsy for a rule-out basal cell or something like that. Okay, so then we'll shift to cutaneous injury due to physical trauma. And these will include things like friction blister, Talon noir, Acanthoma fissuratum, and then surgery-associated injury. So friction blister is often on the hands and feet. The split is often below the granular layer or within the epidermis, usually higher, basically, compared to other blistering disorders. So that's a very important thing to kind of be aware of if you're thinking that could be friction blister. Minimal inflammation compared to other inflammatory immunobolus processes. The keratinocytes may show some reticular degeneration, but not always. And if it's low enough, the split's low enough, you can think of epidermolysis bullosa acquisita or PCT, porphyria cutaneous tarda as far as the differential. So this is what I mean when the split occurs higher up in a friction blister, basically right in or below the granular layer here, maybe some reticular degeneration of the keratinocytes there with inflammatory crust there, but really not much as far as inflammation going on underneath. So Talon noir, also known as black healer or calcaneal petechia, we see it every once in a while biopsied. By far the most important thing is to rule out melanocytic, because clinically these can look like melanoma. So we have to look for not just the melanocytes, but look in the intracorneal area and make sure that there's no hemorrhage there. And then this is also associated with athletic activity. So it's kind of a cousin of friction blister, at least that's what I think of it, as a cousin of a friction blister, traumatic induced, with the addition that you get hemorrhage instead of just a split. And iron stains aren't going to help because they are typically negative in these cases. And here we have an image that shows very nicely what we see here. Sometimes you don't always get such a nice intracorneal blister with hemorrhage. Sometimes you have to actually cut levels into it to find it. So if you don't see anything initially, make sure you cut your levels into the block, looking not only for melanocytic, which is often the case, rule out melanoma or atypical melanocytic, but also looking for the hemorrhage to make your diagnosis. So then we have this condition, Acanthoma fissuratum, Granuloma fissuratum, not very much biopsied very often, but it is good to at least be aware of it. I think of it as kind of sort of a cousin to chondrodermatitis nodularis. It's basically induced by the same process. It's friction or pressure, in this case because of spectacle frames or glasses. But in the oral cavity, if you have it you can get it because of malfitting dentures, and you call it epulous fissuratum. So important to be aware of that as well. So because of where the glasses go, you either get it at the nose or at the crease between the ears and the scalp. And as I said, chronic pressure or trauma, it's basically changes of lichen simplex chronicus, but you may have a little small area of a depression as well. And there's no granulomatous infiltrate. It is a misnomer in that sense. Okay, here we have an example from Lever. And this biopsy very much to me looks like chondrodermatitis. You get a shaved specimen, you get LSC, lichen simplex chronicus, like changes of the epidermis, and this sort of ectatic vessels underneath, fibrosis of the papillary dermis underneath. So this is something we see very commonly. This is talking about surgical curettage and electrodesiccation. You see elongation and stretching of keratinocyte nuclei and of basophilic collagen necrosis. We see it in curettage sites a lot. We see it in electrodesiccation specimens. So it's a pretty common artifact to see. And I think it's something they'd like to test you on boards a lot. And here's what I mean. You get these squiggly, elongated nuclei within the epidermis and sort of this collagenous, amorphous appearance to the collagen right here. Maybe a little bit of inflammatory cells thrown in as well. Another one from an example from liver, showing several of these images are showing examples of it. This one right here in particular is very nicely showing the damage to the keratinocyte nuclei, this one as well. And this down here shows this more kind of basophilic degeneration that you can sometimes see. Okay, so then we'll go ahead and switch to our unknowns. I have a handful of unknowns that I can show some images of in just one second. Okay, so we have some images we can go over here, a handful of cases that go with the topics I just spoke about. So I'll kind of go through this. This is a shave biopsy, and we can see that there's a couple of things going on here. There's obviously a lot of ulceration here, and we kind of got this inflammatory exudate. So we can see that it's involving, the process is involving the epidermis, but additionally, the dermis is not entirely normal either. You have this sort of fibrosis look, this very kind of almost sclerotic look. You've lost the fibrillar quality to the collagen that you normally see. Even away from the ulcer in areas like this, you can see this is sort of more or less what we'd expect normal collagen to look like, this very fibrillar quality. But you compare that to this side over here, you can clearly see that there's something going on with the collagen. So then we get the history, and we know that this patient has actually been exposed to radiation. So it's almost two things going on as far as the acuteness of the injury. We got more acute injury in the epidermis here, and more of a classic chronic injury with obliteration of pilosebaceous units and with this fibrosis. And then, as I said a few times, we look for these radiation fibroblasts, which can often find and very helpful in the differential diagnosis if you're thinking of things like morphia or lichen sclerosis. These types of cells, these sort of elongated, somewhat hyperchromatic fibroblasts that you see associated with radiation. So let me show you this other case. This is a more recent case that I had, actually, and it's in the same category of radiation dermatitis. You can see there's actually a split right here within the papillary dermis. And if you look closely at the actual papillary dermis here, you can see it's got this very homogenized look, almost lichen sclerosis-like, very lichen sclerosis-like look. And here we do have normal over here, normal collagen to compare it to. So we can see this half over here looks very different from this half over here. And if we didn't know anything, the first thing I would think about in this image here would be lichen sclerosis with this homogenized look to the collagen. And the split is from just weakening of all this collagen because it's been altered. But then if we look closer underneath, we can see that there's a lot of vascular ectasia here. So that's our first clue that this is radiation. But additionally, we also have areas, which I marked here, that have these sort of larger atypical hyperchromatic fibroblasts, or these radiation fibroblasts. And it's distinguished from malignancy because they're not crowding, clustering together. They're just kind of interspersed in between these collagen fibers at distances from each other. So it's not a malignant process, but it is, it's a nice way of making your diagnosis for radiation injury. And then the last thing I saw here with this vascular ectasia, I mentioned that earlier, is something that goes along with radiation injury. Lots of vascular ectasia, not only up high, but even down low, down over here where we get these smaller vessels that are markedly ectatic, more so than we would expect to see in any other condition. So this patient did have a history of radiation treatment for breast carcinoma, actually. So it correlated well. Okay, we'll go on to our next case here. So this is a case that's very common that we see in our daily practice in DermPath. We see that this is actually in the lips. And centrally, we can see that there's this absence of epidermis right here. And right here, we sort of have this altered quality to the underlying collagen right here. And if we look at the edge where the edge of that absence of epidermis, you can see that, again, that squiggly sort of lines, these elongated, almost like stretched out nuclei. So this is a nice example of a curettage specimen or electrocautery artifact. And again, something we see very commonly. And I think something that they like to test a lot on boards. All right, we'll go on to our next case. So here we have sort of this shaved biopsy that's been cut into 4 pieces. And what I notice at low power kind of scanning this slide, besides the arrow that I just put there, is that we have this thickened epidermis, so almost like an LSC, like in simplex chronicus type picture, even with a little bit of this vertically oriented collagen fibers and vascular ectasia. And if I didn't know anything, if you told me this was the ear, I might think of late stage of chondrodermatitis. So you really have to, so this is an example of Acanthoma fissuratum, and you really have to know the site before you really tell the difference between the two. Here's almost an impression right here, or a little divot. It's one of the things that they say that you can see in Acanthoma fissuratum. And we've had ulceration here. So this is a lot of pressure, more acute pressure from the glasses that this person was wearing. So we got more of an acute process here and more of this lichen simplex chronicus or chronic process right here. So a nice example of Acanthoma fissuratum. Here we have some hemorrhagic scale crust, or basically a scab that goes with the ulceration over here. All right, so we'll move on to our next case. So here we have a punch biopsy, and it looks like we are probably not on areas that we would think of as being sun exposed. It doesn't look like we have a lot of pilosebaceous units, so probably not the face. So I would imagine that this is probably the trunk, maybe the extremities, thicker skin. And as I scan around, I see that there's basket weave hyperkeratosis or basket weave keratosis. Not really much in terms of alteration of the stratum corneum here, and really not much scanning power that I can see of the epidermis change here. The dermis, not much inflammation. So this is almost something I would think about very minimal pathology. I don't see much going on here. I'd probably look around a little bit, and if after a while didn't find anything, I'd have to just look at the clinical history to see if I could get some help. Not usually the way I like to do things, but in this case, I think we'd have to. And after I got the clinical, I'd say, okay, well, I need to look a little bit closer, maybe around here where I made this arrow. And you can see an occasional, very rare necrotic keratinocytes right there. And I believe there was maybe one right there. So very, very subtle finding. A slight interface process, maybe a little obliteration of the dermal epidermal junction in patchy areas here, but not much else. I mean, maybe a little bit of vascular ectasia and inflammation. So we'd have to get the history. We'd find out from reading the requisition or from talking to the clinician that this patient had reticulated lesions, maybe on the trunk, maybe on the extremities, and that they were exposed to heat. So this is actually a nice example of Erythema ab igne. But the point I want to make is that this can be a very difficult diagnosis, almost like an invisible type process. You have to really have a high index of suspicion to be able to get it just from this, and correlate it clinically. Call your clinician, see if it matches, see if it's something that maybe they didn't even think of, because sometimes it can be difficult to diagnose clinically as well if it's a subtle finding. Here's another necrotic keratinocyte. But not much else going on here. All right, so we'll go on to the next case, which is this one. All right, so here we have a nice punch. And what's obviously acral skin, we got very thickened stratum corneum, hypergranulosis. We have a nice lamina lucidum there as well. But the primary process actually is going on down here. You can see you got that sort of a busy dermis with a lot of lymphocytes, superficial and deep. These are all lymphocytes. We can tell that they have that small blue cell quality to them. And we have some of them extending down into the eccrine structures right here, which is what I marked right here, and surrounding eccrine glands right there. So the biggest clue that I mentioned earlier for perniosis is what this is. Note that we are lacking the papillary dermal edema. This is the one thing that I said was variable earlier. If you look close at the junction right here, you can actually see an occasional necrotic keratinocyte. So interphase change, you may think about, or some people may think about lupus erythematosus associated, or Chauvelaine's lupus erythematosus. But again, it's not 100% finding. And as a matter of fact, this patient happened to be a COVID patient. So this is an example of COVID associated perniosis. So a very interesting case, something we've been seeing more and more lately. All right, and then we'll move on to the next one, which I believe is our last one. So another shave biopsy, and we can see something going on in the stratum corneum, but also before we go there, we look at our normal epidermis, normal stratum corneum. We can tell it's acral skin or acral skin with a nice lamina lucidum right here. But a very obvious, and it's not always this obvious, intracorneal blister with a hemorrhage. So a very nice example of Talon noir. And as I said earlier, the most important thing by far is to rule out any kind of atypical melanocytic process melanoma, as this can often mimic it clinically. So in this one, we got very fortunate is because we can see this very marked split here with the hemorrhage. As I said earlier, sometimes you don't get that lucky. It'll be very focal, and you really have to do your serial sections, your level sections, to make sure that you go looking for it and give an explanation as to what is going on with the pigmentation, with the clinical pigmentation. So a nice example of Talon noir. I believe that was our last case. Let me just make sure. So I hope that was helpful for everybody, and it is our last case. And I hope it was a good lecture. Thank you for joining, and have a good rest of the day.